What's up, Laura?
Hey, what's going on?
How's your shift going?
Pretty good. I have an interesting patient today.
Oh yeah? The patient in 305?
Yeah, that guy.
Okay, I had him last night.
Oh, okay, so you kind of know about his deal?
Yeah, a little bit.
Yeah, that's crazy. He just lost 30 pounds in like a month and a half. Can't believe he has stomach cancer.
Hey, Laura, Jonathan, this is Brett, new nurse on our floor.
Hey, how's it going?
Good, how about you guys?
He just graduated from National 3 months ago, so he's super excited to be here. Go ahead and take a seat. We're all on our break right now.
So hey, how are you liking the hospital so far?
It's going really well. I really enjoy it up here.
Oh, that's great. You graduated from National too? So did Jonathan and I.
Oh, that's really cool. We all went to the same place.
Oh yeah, I actually graduated with Laura a year and a half ago. I'm just glad I'm done, yo.
What patient are you taking care of today?
Oh, I'm taking care of patient in 311.
Oh yeah, that's right. What's his story? What's his diagnosis?
He's a 71-year-old male. Came in 2 days ago with a chief complaint of facial droop, slurred speech, and muscle weakness. He's a full code, allergic to penicillin and morphine. He has a past medical history of smoking, 3 packs a day, hypertension, diabetes. His last vitals were 36.5 temp, a pulse of 81, BP 145 over 73 with a respiratory rate of 17 and O2 sats of 98. And he just went down for CT.
Sounds like you've got an interesting case. Do you feel comfortable taking care of a patient with an aneurysm?
Yeah, I feel pretty comfortable, but I mean, I'm always open for tips and stuff, so is there anything you guys have for me?
Oh, that's actually really good because Laura has a lot of experience working with patients who have aneurysms, so she'd be a great resource for any questions that you have on taking care of your patient.
So as I'm sure you remember from school, the technical definition of an aneurysm is a permanent localized dilation of an artery enlarging to at least 2 times its diameter, right?
Mm-hmm.
So there's 2 types. There's the fusiform, which is a diffuse dilation affecting the whole circumference of the artery, or there's a saccular, where when you're looking at it, there's at the artery, there's an outpouching affecting only a specific portion. So what does an aneurysm do? Just a quick pathophysiology review. The arterial wall is weakened by either a congenital or an acquired problem or by trauma. So it affects the middle layer of the artery, causing weakening, and there's a stretching effect to the inner and outer layer of the arterial walls. So as the vessel widens, tension on the walls increase, causing further widening, and it enlarges the aneurysm, making rupture more likely. And ruptures are really dangerous. So having an elevated blood pressure increases the risk of rupture. So there's obviously 2 different types. There's the abdominal aortic aneurysm, called a AAA, that's going to be here, and then there's the thoracic aortic aneurysm, called a TAA. They're not as common as the AAA, but they still develop in different sections of the aorta. The symptoms of an aneurysm usually manifest when the existing area is put under pressure or when there is a rupture. So as I said, the ruptures are really dangerous due to the abrupt and massive hemorrhagic shock that occurs, so it becomes life-threatening. So the most common causes that we usually see here are atherosclerosis, of course followed by hypertension, which you said your patient has, hyperlipidemia, and cigarette smoking. Your guy was a smoker, right?
Yeah.
So age, gender, family history play a part. Chronic inflammation or blunt trauma, like a car accident, can cause a TAA as well. So when you go back, I'd say, or when your patient comes back from CT, I should say, make sure and take a look and assess him. For a AAA, you'd be looking for a prominent pulsating mass in the abdomen at or above his umbilicus. And you'll be hearing a systolic bruit over the aorta, tenderness on deep palpation, and abdominal or lower back pain. On a TAA, it's going to be more of pain extending up to the neck and shoulders, the lower back, abdomen, and he'll have syncope, dyspnea, increased pulse, cyanosis, and generalized weakness. And when there is a rupture, which hopefully he won't have one, severe abdominal back pain, lumbar pain radiating to the flank and groin, hypotension, increased pulse rate, sinus shock, and a hematoma in the flank area. So those are just some things to look out for.
What did I tell you? This girl knows a lot about aneurysms.
Oh yeah, you do know a lot. So if I went back into his chart, what other diagnostic tests should I be looking for?
Actually, you know who's really good to ask that question to is Jonathan. He knows a lot about the diagnostic tests related to aneurysms.
Alright, so the purpose of our diagnostic test is pretty much to to confirm the presence, the size, and location of the aneurysm. We have 3 basic type of tests. We have the CT, we have the angiogram, and we have an ultrasound.
My patient's in CT right now. What should I be looking for when it comes back?
Okay, so with the CT, we can do it with or without contrast. In this case, we would be doing it with contrast just so we can see the flow and whether it ruptured, if it's bleeding out, and where the blood's going.
Okay, thanks. What about the other tests you mentioned?
CT scan is our gold standard to check size, location, and the perfusion of the aneurysm. But we can also do an angiogram, which in this case it would be a cerebral angiogram, and an ultrasound. Ultrasounds are typically a little bit more just with the abdominal.
Okay, thanks. Is there any more that I should be looking for?
There are a few other tests that we can do. We can do an MRI. We can do an echocardiogram. Echocardiogram would typically just be of thoracic area. With the ultrasound, typically it would be in just the abdominal area.
Okay, thanks. Is there any more that I should be looking for?
Yes, in your case, since it's a cerebral aneurysm, to check for possible hemorrhaging, we can do a CSF test. And we would just puncture in the lumbar and aspirate, check for blood.
Oh, thanks. This is really helpful.
I actually have my iPad here. I can show you some examples. Alright, so here's an example of an aneurysm in the skull. You can see the aneurysm right here. Alright, and here's an example of an aneurysm in the aorta. You can see the lumen of the aneurysm right here. Okay, and here's the last example. You can see the clot right here and the lumen of the aneurysm right here in the center.
Wow, guys, that was a lot of great information. So when I get back out on the floor, I'm going to make sure he's still compliant with his hypertension medicine, making sure he has diabetes controlled, because these seem to be things that can cause further complications to his rupture. Once the CT comes back and I get his results, I'm going to contact neurology and IR to make sure everything is going smoothly.
So what did I tell you, Brett? Laura and Jonathan have a lot of information. The one other thing you're going to look out for, Brett, is a AAA. And a AAA is an abdominal aortic aneurysm. And these are particularly a high risk, and they're often unrecognized until there's an actual rupture. Once there's a rupture, the AAAs have a high mortality rate. There's actually about a 20% survival rate of patients with a AAA. And most of the time they die before even reaching the hospital. If the AAA is 5 centimeters or less, there's a pretty good chance of them surviving with surgeries. But if it's more than 5 centimeters, there's a pretty high fatality risk that goes along with it. I actually got 2 journals sent to me from some colleagues on trying to bring down the prevalence and fatalities associated with AAAs. One recognized some interventions that the patients can do for themselves to prevent aneurysm occurring. And those were things that already the patient should be doing to manage their hypertension. So stop smoking if they are, lead a more active lifestyle, restrict fluid and salt intake, reduce their weight, reduce alcohol intake, and to eat healthy. Another one of the articles had mentioned about screening, recognizing patients that have a higher risk of having a AAA and having them screened to see if there's any interventions that the doctors or surgeons can do. And with the study that they did, they saw that 90% of the people who had AAAs were smokers or had a smoking history, and 51% of them had hypertension, and 15% of those patients that they studied had diabetes. And I think your patient had your patient that you're taking care of does have a history of smoking, does have hypertension, and is managing diabetes. So recognizing those risk factors can help make sure that this patient doesn't have any complications such as a AAA and having their life cut too short.
Thanks, guys. That was a lot of great information. Please send those to me, and I'll see you guys out there.
Hey, well, it was nice meeting you, and welcome to the unit.
Yeah, good luck with your patient. Let us know if you have any questions.
All right, well, thanks you guys for helping us out. And Brett, I think our break is over. I think we got to get back on the floor and start saving lives.